Welcome everybody. My name is Graciana Najim. I'm a psychologist and a gerontologist. I'm a member of the AGA and also treasurer elected for the IAGG. Now I'm going to present the oral presentation about life course traumas and cardiovascular disease and the role of accelerated aging, an analysis of 104,939 UKB participants by Ms. Sinji Kao. Sinji Kao is a PhD candidate in School of Public Health at Sejong University. Her research focuses on geriatric epidemiology involving geriatrics, epidemiology, and sociology, studying the new and traditional aging measures. Welcome, Ms. Sinji Kao.
Hi everyone, I am Sinji Kao, a PhD candidate at Zhejiang University. Today I am going to share the paper, Life course traumas and cardiovascular disease and the role of accelerated aging, an analysis of 104,939 UKB participants. The left figure shows the latest data from WHO. CVD, including ischemic heart disease and stroke, is a leading cause of death, accounting for about 27% of global deaths. Emerging evidence has consistently recognized early life traumas as potent contributors to CVD. However, limited emphasis given to traumatic experience over the life course. A life course approach addresses how life course exposures affect health inequalities using various models, such as critic periods model, a cumulative risk model, and chains of risk model. But how do life course traumas influence CVD remains unclear. It's highly possible that traumas lead to physiological dysregulation, manifesting as vulnerability to disease, which in turn increases the risk of CVD. In fact, it's reported that traumas accelerate aging at cellular and phenotypic levels. Also, phenotypic aging has been suggested to predict disease, such as CVD. The question is, how do life course traumas get under the skin and result in the onset of CVD? The extent to which phenotypic aging mediates the associations between life course traumas and CVD remains unexplored. In this study, we used the data from more than 100,000 mid-aged and older adults participating in both the UKB baseline and the online mental health questionnaire survey. We grouped participants in two ways. First, we assessed childhood traumas occurred before 16 years of age, adulthood traumas occurred after 16 years of age, lifetime traumas in whole life. To assess the cumulative life course traumas, we summarized the childhood, adulthood, and the lifetime traumas. To obtain an all traumas variable, we defined subgroups as mild, moderate, and severe for them separately. Second, we merged mild and moderate subgroups into a non-severe subgroup and then defined 4 life course traumas profiles based on childhood and adulthood traumas. As follows: non-severe traumas across life course, non-severe childhood and severe adulthood traumas, severe childhood and non-severe adulthood traumas, and severe traumas across life course. With a visible phenotypic age at baseline and a certain prevalent CVD at a time attending online mental health questionnaire survey. We first estimated the associations of childhood, adulthood, and lifetime traumas with CVD. Next, we estimated the associations of life course traumatic profiles with CVD. Finally, with final age, we estimated the mitigating role of phenotypic aging in life course traumas and CVD. As the table shows, we observed that subgroups of life course traumas were associated with higher odds of CVD. even further adjusted for final age in Model 3. Left post-traumatic profiles were associated with higher odds of CVD as well. For instance, participants who experienced severe traumas across left course had 33% higher odds of CVD. Then formal mitigation analysis were performed. First, as shown in the table, participants who experienced moderate or severe traumas exhibited higher final age. Significant associations were also found for those who experienced severe traumas across left course. Next, the associations of phenotypic aging with CVD were estimated. A 1-year increase in the final age increased the odds of CVD by 3%. The robust associations of final age with CVD stratified by subgroups of left post-traumas were found. Finally, the table presents the mitigation analysis for left post-traumas. When comparing those in the severe subgroup with those in the mild subgroup, 3 to 10% of CVD events were mitigated by final age. Also, final age mitigated 5 to 6% of CVD events in those who experienced left post-traumatic profiles. In conclusion, in this large sample of middle-aged and older adults from the UK, childhood, adulthood, and lifetime traumas, as well as diverse left post-traumatic profiles, were associated with CVD. The study also showed that phenotypic aging partially mitigated the associations, providing evidence to improve our understanding of the pathway from left post-traumas to CVD. The findings underscore the importance of policy programs targeting traumatic events over the left course in ameliorating inequalities in aging and cardiovascular health. Finally, I wish to thank my supervisor, Zhu Liu, and my colleagues. That's for my presentation. Thanks for your attention. Any comments or suggestions is highly appreciated. Thank you.
Now, I'm going to present an oral presentation about factors associated with mortality in patients after 1 year of undergoing hip fracture surgery by Dr. Diego Andrés Chavarro Carvajal.
Hello. Today, I will be presenting a study we conducted together with doctors Diego Andrés Chavarro, Samir Alejandro Herbachan, Sandra Milena Caicedo, and Carlos Alberto Cano. The title of our study is The Factors Associated with Mortality in Patients After 1 Year of Undergoing Hip Fracture Surgery at San Ignacio University Hospital in Bogotá, Colombia. By 2050, the occurrence of hip fractures is expected to rise to 6 million worldwide. Hip fractures increases with age. 85% of all hip fractures occur in people over 75 years old, and 2/3 of them in people over 80 years old. Mortality rises 1 year after. Different studies show that mortality after 1 year of a hip fracture ranges from 14 to 36%. It is relevant to identify and describe the direct risk factors associated with mortality with patients suffering hip fracture, as this allows us to assess the probability of death and to take appropriate action when possible. This in order to improve the prognosis and carry out early intervention. However, research on a risk-associated mortality in the elderly is scarce in our region. The objective of this study is to describe the factors associated with 1 year mortality in patients that underwent hip fracture surgery in San Ignacio's University Hospital OrthoGeriatrics program between 2017 and September 2020. This was an analytical observational study in patients over 65 years old admitted to the San Ignacio University Hospital for no pathological hip fracture and who were treated in the OrthoGeriatrics program. The information was analyzed as a nested case control study through a univariate logistic regression model, and to control the effect of the other variables, a multivariate logistic regression model was applied. The telephone follow-up was conducted to 202 subjects, and we had a follow-up loss that represents 3%. The results show that most of the subjects were female, 69%. The average age was 82 years old, and 60% of the subjects had nutritional risk and malnutrition. Most of them had mild dependencies, and 52% had dementia. The most prevalent comorbidity was arterial hypertension, 69%. Hospital complications represent 47%, and delirium was the most prevalent hospital complication, was 28%. The results show that mortality 1 year after surgery during the period of 2017 to 2020 was 17.82%, and the factors associated with mortality with the highest statistical significance were moderate dependence, malnutrition, hospital complications, and being older. According to the results found in this study, it can be concluded that having a moderate dependency, malnutrition, presenting in hospital complications such as delirium, and being older are associated with the higher risk of mortality. So that by determining these factors associated with mortality, an early intervention can be carried out through a comprehensive geriatrics assessment, and thus be able to reduce them as much as possible to provide a better chance of recovery and have a greater impact of the prognosis of older adults with hip fracture. Thank you. I'm looking forward to your questions.
Now, the oral presentation is about perception of social inequality in 40 and 34 countries, an age period cohort analysis by Dr. Elena Chui.
Thank you, everyone. The title of my presentation today is Perception of Social Inequality in 34 Countries, an Age Period Cohort Analysis. I would like to first of all thank my colleague, Luisa Bataha. Slide 2. Social inequality has increased in the recent decades, such that gains have been concentrated with a small group. However, people's perception of inequality often does not concur with reality. In addition, the extent of biased perceptions of inequality varies within countries and across countries. Indeed, perceived inequality and not the actual level of inequality has been found to correlate strongly with demands for resources redistribution. Although the mechanism is not clear, inequality has been associated with conflicts and violence. Slide 3. Studies have established the associations between the perception of social inequality and indicators of socioeconomic status, such as income, wealth, and social mobility. As social inequality has increased, it is less clear how the perception of inequality has changed. Changes in the perception of inequality can be due to age, period, and cohort effects. Slide 4. This is the aim of the current study. We aim to decompose trends in the perception of social inequality into age, period, and cohort effects, and examine whether the perception of social inequality was associated with perceived social conflicts while taking into account demographic variables such as gender, education, and employment status, which is known to be associated with perceptions of social inequality. Slide 5. This is the method of the current study. We use the 5 waves of cross-sectional data from the International Social Survey Program, collected in 1987, 1992, 1999, 2009, and 2019. We have over 130,000 individuals from 34 countries The dataset included 36 countries. However, the key variables were not included in the datasets from Japan and Canada. About half of the participants were women. The age range was 15 to 105 years. The mean age was 47 years. Measures. For level 1 variables, we have the perceptions of social inequality assessed by 2 items. Get ahead, how important is coming from a wealthy family? Get ahead, how important is knowing the right people? Participants responded using a 5-point Likert scale. A higher score means a high perception of social inequality. These 2 variables were correlated at 0.38 because they were not highly correlated. We used them as separate dependence variables, rather than using the mean of the 2 variables as the dependence variables. Slide 6. Social conflicts were measured by 3 items. Participants were asked to rate how much conflicts is there between the poor versus rich, working versus middle class, and management versus workers. Participants responded using a 4-point Likert scale. A higher score means a higher perception of social conflicts. These 3 variables were correlated in the range of 0.47 to 0.55. Because the variables were not highly correlated, we used them as separate independent variables, rather than using the mean of the 3 variables as the independent variable. Slide 7. The demographic variables included age, gender, marital status, education, working class, and top-bottom self-placement. Participants responded to the question, in our society, there are groups which tend to be towards the top and groups which tends to be towards the bottom. Below is a scale that runs from top to bottom. Where would you put yourself now on this scale? Participants responded using a 10-point Likert scale. A higher score means higher in self-placement. Slide 8. For level 2, period and cohort were entered in the model as random effects. Slide 9. For level 3 variables, inequality was measured using the Gini index. Country was entered as a random effect. Analysis. We used the hierarchical age period cohort cross-classified random effect model. This statistical method has been applied to examine the effects of age period and cohort using cross-country data successfully. Slide 10. Age was centered at the grand mean and recoded into units of decades. And I'm going to skip the next 2 points. Other level 1 variables were group mean centered, and level 2 variables, Gini index, were grand mean centered. Slide 11. The hierarchical age period cohort cross-classified random effect model is actually a 3-level multi-level model with 2 cross-random effects, country cohort and country period. The level 1 model can be represented by this equation. Slide 12. The level 2A and 2B models can be represented by these equations respectively. Slide 13. The level 3 model can be represented by this equation. Slide 14. Here are the results. First, the descriptive statistics. I would like to note the means of the 2 dependence variables, the perceptions of inequality, on a 5-point Likert scale, and for the means that are around 2 and 3, that means the means are at around the middle of the scale. Slide 15. Here are the results of the age period cohort analysis. This table presents the fixed effects at level 1. Basically, almost all level 1 variables are significant except age in the mode of wealthy family and work status, others in the mode of right people. Slide 16. This table presents the fixed effects at level 2. The only variable that showed a significant effect was top-bottom self-placement. Slide 17. Here is the graphical representation of the effects of age on the perceptions of social inequality. Although the quadratic effects were significant for both dependence variables, as we can see, the effects were very small. Slide 18. Here are the graphical representations of the random effect of period. We can see differences across periods within each country. However, the differences were small. Slide 19. Here are the graphical representations of the random effect of cohort. Again, we can see the differences are pretty small across the countries. Slide 20. These two plots present the random effect of country. The differences are small, with most error bars overlapping with each other. Slide 21. To examine the significance of the random effects of period and cohort, a likelihood ratio test was conducted to compare the models with and without the random effect of the period and cohort. Results of the likelihood ratio test showed that the models with the random effects of period and cohort had a bit better fit than the models without the random effects. Thus, we go ahead and interpret results of the model, including the random effects of period and cohort. Slide 22. The findings show the significant quadratic effect of age on the perception of social inequality. The random effects of period and cohort were significant. Perceived conflicts between the poor and rich, working and middle class, management and workers were positively associated with perceived social inequality. However, considering the small effect sizes, results were inconclusive as to whether the effects of age, period, and cohort on the perception of social inequality have reached practical significance. Slide 23. While the actual level of inequality has increased since 1987 in wave 1, the perception of social inequality may not have changed accordingly. Perception of social inequality has implications on demands of resources redistribution. Future studies are needed to understand the sources of temporal changes in the perceptions of social inequality. Slide 24. I would like to thank my colleagues for their help in the statistical analysis. And slide 25. Thank you very much.
And now I'm going to present sarcopenia's assessment and quality of life in a reference elderly healthcare unit in the city of Sao Paulo by Dr. Marcelo Cruz. Dr. Marcelo Cruz graduated in medicine at the Pontificia Universidade Católica of Sao Paulo. Geriatrician graduated at Santa Casa de Misericordia de Sao Paulo, MBA in Health Management and Economics, full member of the Brazilian Society of Geriatrics and Gerontology, currently clinical director at the Ambulatorio Médico de Especialidades de Idosodo en Sao Paulo. Welcome, Dr. Marcelo Cruz.
Dear Examination Board members, good morning. It's a great honor to be able to participate today with you in the 22nd World Congress of Gerontology and Geriatrics. I'm grateful for the opportunity to present this work to you all. This work was born during my MBA's process, motivated by a need to combine such as important subjects in my daily clinical practice. As such, how governments, members sees and manages public health services in Brazil. Brazilian population has been aging quickly and more rapidly than in developed countries. Literature shows that individuals' aging process can lead to a loss of strength and muscle mass. Sarcopenia is a multifactorial condition that can affect up to 30% of elderly people, usually associated with several negative outcomes as stumbling and qualities of life worsen, increased physical disability and mortality. Among the conditions that compose the aging process, one in particular draws attention due to its importance. However, less known in clinical practice. There are a few studies that can relate quality of life and sarcopenia, and many instruments are non-specific for this condition. In 2015, Bodart and colleagues created the Sarcopenia-Related Quality of Life Questionnaire, SARQUAL, a questionnaire with 22 questions and 7 domains, including physical and mental health, locomotion, body composition, functionality, daily living activities, leisure activities, and fear. This study aims to assess if patients are getting sarcopenias properly, diagnosis, and to assess their quality of life. 60 patients were selected and divided into 2 groups with 30 subjects each. The first one with patients who had the history of tumbling and or fractures, and a control group with patients who didn't. The 2 groups were evaluated for sarcopenia using measures derived of hand grip strength, calf circumference, and gait speed. As measures related to quality of life, they were asked to complete SARQUAL's questionnaire. Here, I would like to add that we use calf circumference instead of bioimpedance or DEXA due to the limitations found in our service. In the first group, almost 27% are male and 73% female, and in the control group, 32% male and 67% female. In both groups, 45% consider normal tumble, 40% don't refer to the doctor that they tumble, and 53% refer that they weren't questioned about tumbles at the medical appointment. This shows that even the most common complication of sarcopenia isn't so important for patients and doctors. First group tests analysis shows that 6.6 were diagnosed with severe sarcopenia, 16.6 with sarcopenia, 6.6 with sarcopenic obesity, 23.3 with probable sarcopenia, and 46.6 with no sarcopenia. The control group, same analysis, shows that no patient was diagnosed with severe sarcopenia or sarcopenia, 3.3 with sarcopenic obesity, 30% with probable sarcopenia, and 66% with no sarcopenia. So you can see here in this graph the difference between the tumbling group and control group that has only 3.3 sarcopenic obesity. All the confirmed cases of sarcopenia are in the tumbling group. First group's quality of life analysis shows an average about 57.7 points, and 40% of patients has scored below 50 of 100, and among these, 58.3 had sarcopenia. Compared to second group, same analysis, the average was 68.8 points, and 6.6 of patients had scored below 50, and among these, 3.3 had probable sarcopenia. The graphs we can see, the tumbling group, 40% scored below 50, and only 6.6 scored below 50 in the sarcoma. In both groups, all patients analyzed in this study were underdiagnosed for sarcopenia. First group's patients had a greater number of diagnoses for different degrees of sarcopenia and showed a worse quality of life when compared to the second group's patient. Concluding, sarcopenia is a little-known, multifactorial, and underdiagnosed illness, which is related to a greater number of tumblings and worsening of the elderly's quality of life. The sarcopenia's assessment, which can affect up to 30% of the elderly, has received special attention in the last 2 decades due to its relationship with health service costs and quality of life's impact. Nowadays, approximately 50 million people in the world are affected by this condition. However, as it isn't an ordinary topic to the most health professionals, this number may be underestimated. Our study showed that 100% of the patients were underdiagnosed for sarcopenia with no differences between groups, even though realized in a specialized geriatrics and gerontology service. This fact made us raise some hypotheses that could justify sarcopenia's underdiagnosis. Among them, a public health system increasingly pressured by an increasing demand with limited financial resources, which led to needs for a high number of short-term appointments. Another one is the poorness of infrastructure and lack of equipment to enable diagnosis, most of all in primary care service, such as physical space, absence of a dynamometer or bioimpedance device. Finally, but not less important, we found out that the lack of knowledge on the subject and consequent training for the correct sarcopenia diagnosis. Sarcopenia is more frequently observed in patients who have suffered falls, and due to the significant difference found out between those who had a fall and the diagnosis of sarcopenia, and between those who had a fall and a worse quality of life, we suggest that further studies should be carried out in order to improve the understanding on these subjects. Due to this work's results, new trainings has already been implemented along with our group of professionals. A new protocol has been established for better investigation and adequate treatment of sarcopenia. Thank you very much.
And now I'm going to present the oral presentation by Dr. Gloria Goodman, that it's about perceived consequences on the COVID-19 pandemic on LGB and heterosexual Canadian older adults. Dr. Gloria Goodman is professor of gerontology at Simon Fraser University in Vancouver, Canada.
Lesbian, gay, and bisexual older people are thought to be amongst the most vulnerable to the ravages of the COVID-19 pandemic due to the pre-existing disadvantages that many of them have experienced. And some of you will be familiar with those, that in terms of stigma, of kinds of discrimination that they have experienced over their earlier years, as well as the fact that generally they tend to have poorer mental and physical health. But when all is said and done, there are very few studies available that compare LGBT older adults and heterosexual older adults with regard to the consequences of the pandemic for themselves and for their households. We aim to determine if and how perceived COVID-19 consequences differ among and between homosexual and heterosexual older adults. And the secondary objective of our study was to examine the association of the perceived COVID consequences with self-rated mental and general health. The study uses data from the Canadian Longitudinal Study of Aging, which is a cohort of some 51,000 Canadians aged 45 to 85 at time of enrollment, which was between 2012 and 15. And they are followed up every 3 years and will be for at least the next 20 until 2033. We analyzed data of participants age 55 and over at the first follow-up, which was the one that contained some questions about elder abuse. We also took, these people also took part in a COVID-19 study, which was conducted between April and December of 2020, with an N of some 24,000. This presentation deals specifically with some questions from the COVID-19 study. And we used weighted analyses because it's a very complex service design, and we wanted to be able to generalize to the Canadian population as the CLSA leadership recommends. The COVID-19 study exit interview asks participants to describe the consequences or to rate the consequences of COVID-19 on them and their households using a 5-point Likert scale. We regrouped this into 3 categories of very negative, negative, no effect, or very positive. And the main independent variables were gender and sexual orientation, with self-rated health and mental health as explanatory variables. This slide shows the actual questions, which, as you can see, ask the respondent to take everything about COVID-19 into account and then to describe the consequences on themselves and their households using the scale shown. This slide shows our questions for health and mental health. The overall weighted prevalence of perceived COVID-19 consequences being negative was just a little over half. But we were surprised to find that it was heterosexual men who had the highest negative responses. And we also, not unexpectedly, found that perceived negative consequences were more common amongst those with fair to poor mental health and fair to poor general health. there were only small differences as a function of gender in the proportions who described the consequences of COVID-19 on themselves and their household as being negative. The next slide shows that there was a substantial difference and a significant difference between the heterosexual and the homosexual population. And what we see in this slide is that the largest percentage of people viewing these consequences as negative as being heterosexual men, followed by heterosexual women. And this shows the ratings for self-rated general and mental health. In terms of our interpretation of the data, we refer to the Sexual and Gender Minority Health Disparities Research Framework. This is an important framework in that it has 4 levels that are consider individual factors. The second level considers relationships. The third is the level at which the relationships take place, and the fourth level has to do with the broader society. If you look at the individual factors, what we see there is minority stress, which is a theory that is used to explain some of the stresses and strains that LGBT individuals would have experienced. But what it also shows is that there are coping mechanisms that will be used. There are resilience factors that need to be taken into consideration, as well as intersecting identities. We are not just a homosexual. We are also a person who has other identities and other strengths. And so, although the overall prevalence of perceived COVID-19 consequences were higher amongst individuals with lower self-rated mental health and general health, in general, our LGBT, our homosexual participants, were less likely to perceive the consequences of the pandemic to be negative. And we think that this is because of their resilience, as well as their experience overcoming previous kinds of trauma and disasters. We have a series of studies that we have been conducting with the LGBT community over the last several years. We invite you to look at some of our other publications, and we wish to certainly to acknowledge the sponsorship of the Canadian Longitudinal Study of Aging in providing the data for us. This is a Government of Canada Center of Excellence that is funded by the Canadian Institutes of Health Research. We also would like to acknowledge a grant from the Council to Reduce Elder Abuse, which is located within the province of British Columbia, which was specific to analyzing the CLA-SA data and looking at it from the point of view of the impact of the COVID pandemic on both heterosexual and in particular LGBT older adults. Thank you.
Acute effects of electrical muscle stimulation on electromyographic and functional parameters in the elder, a clinical case. This oral presentation that I just present is going to be by Ms. Sara Moya Casanova. She's graduated in physiotherapy in 2017 at the Faculty of Physiotherapy in the University of Valencia. Currently, she's performing her PhD under the supervision of Dr. Pilar Serra at the UBIC Research Group. Her work in the laboratory is mainly focused on aging, frailty, and biomechanical assessment.
Good morning, I am Sara Moya, a PhD student of the University of Valencia. First of all, I would like to thank the organization for giving me the opportunity to present this work, which is entitled Acute Effects of Electrical Muscle Stimulation on Electromyographic and Functional Parameters in the Elderly, a Clinical Case. This is the outline I'm going to follow along the presentation. We will start with the introduction section. As you all know, aging involves progressive physiological changes that lead to a decline of biological functions. Even for Arnold Schwarzenegger, skeletal muscle is especially susceptible to such effects, thus losing up to a third of its strength and muscle mass, a phenomenon known as sarcopenia. Here you have, as an example, a tight muscle of a young, healthy person when compared to a sarcopenic person. The prevalence of sarcopenia in Spain, according to the updated criteria proposed by the European Working Group on Sarcopenia in Older People, has been recently estimated in 28.5%. This implies that 1 in 3 older adults suffer from sarcopenia in Spain. Furthermore, sarcopenia is related to functional impairment, frailty, and even dependence. In this scenario, strategies aimed at preventing or treating sarcopenia are urgently needed. Aside from physical exercise, which is the gold standard aimed at treating sarcopenia, other interventions such as electrical muscle stimulation have been proposed as a therapeutic alternative to counteract muscle sarcopenia. However, there are inconsistent results, and even more, there is no consensus on the protocol or application parameters aimed at treating sarcopenia. In view of the foregoing, the aim of the current study was to evaluate the acute effect of an electrical stimulation protocol on electromyographic and functional parameters in the elderly. Now we are going to present the methods we used for carrying out this study. We present a clinical case of a pre-frail man, a 77-year-old man, who underwent a 4-minute electrostimulation session with the electrodes located on the quadriceps, exactly on the anterior rectum. As you can see in the image. And the session consisted on sitting in a chair with the knees bent 90 degrees and performing an isometric contraction through a convex device against external resistance, a leg extension machine. He received strength resistance programs at level 2 with the following parameters: a contraction frequency of 60 Hz, a ramp of 1.5 seconds, a plateau of 8 seconds, and a descending ramp of 0.75 seconds. The rest period was at 7 Hz with no ramps, and it lasted 6 seconds. Functional capacity by means of the 6 minutes walking test, self-perceived effort by means of the 10-point work scale, and muscle bioelectrical activity by means of electromyography were assessed before and after the intervention. Now we are going to present the results we obtained. After the electrical muscle stimulation session, we observed that the mean muscle electrical activity, we observed that the muscle electrical activity, both the mean and the maximal, increased both for both legs, both the right and the left leg, up to 89.2%, which is pretty good. Furthermore, the proposed intervention resulted in an increase of 2.5% of the distance covered in the 6 minutes walking test. Interestingly or noteworthy, this intervention did not result in an increased self-perceived fatigue. To conclude, electrical muscle stimulation using a brief strength resistance program with the proposed parameters improves muscle bioelectrical activity and functional capacity in the elderly. This strategy may be considered as an alternative or adjuvant to physical exercise aimed at the prevention or treatment of sarcopenia. Finally, I would like to thank our research group, UBIC, for the great support they give me every day, and of course to Mayox Fit, who provided the device necessary to carry out this study. And of course, thank you all for your attention.
And now I'm going to present the oral presentation about social service professionals' knowledge of an attitude towards older persons, implications for continued professional development, CPD, by Dr. Stefan Geyer. Professor Stefan Geyer is an associate professor in the Department of Social Work and Criminology at the University of Pretoria, South Africa. He teaches modules in addiction, gerontology, and research methodology. As a research supervisor, he guides both MSW and PhD candidates in the fields of addiction, social gerontology, and HIV social interventions. As an applied researcher, he research focused primarily on addiction and secondary social gerontology. He's a member of the South African Academy for Science and Arts.
Social service professionals' knowledge of and attitudes towards older persons, implications for continuing professional development amidst global population aging. Introduction. Older populations are increasing across the globe in both developed and developing countries. One of the consequences being that an increased number of older persons will require social services. One of the professional groups pertinently concerned with older persons is that of social service professionals, in this instance referring to social workers and social auxiliary workers. The rationale is that professionals require appropriate knowledge of older persons and a fitting attitude to render effective social services. Data pertaining to these professionals' knowledge and attitude could assist in the design and the delivery of CPD activities. This study is directly aligned with at least 2 focus areas of the UN Decade of Healthy Aging. The lacuna this study focused on is based on various international and national research databases. It was confirmed that there is no evidence of previous research focusing on South African social service professionals' knowledge of and attitudes towards older persons. Hence, the goal of a study to determine and describe South African social service professionals' knowledge of and attitudes towards older persons. Research methods. The study followed a quantitative research approach operationalized through a cross-sectional survey, with the study population being one South African welfare organization with a footprint across 5 of the 9 South African provinces. At the end, 63 participants participated in the study. Data were collected through a web-based survey operationalized through Qualtrics with 3 sections, namely Profile and Palmor's First Facts of Aging quiz in multiple choice format, where we explored overall knowledge as well as positive and negative bias towards older persons when answered incorrectly. To measure attitude, Frapponi's scale of ageism was used to determine overall ageism as well as 3 constructs, namely antilocution, discrimination, and avoidance. Permission was obtained from the welfare organization and ethical clearance obtained to conduct the study. Research results and discussion. From the profile of the respondents, it is clear that at the time of the study, the mean age indicated that most of the respondents were in middle adulthood. As would be expected from this professional group, most identify as female, with most of them being registered social workers with the highest qualification being the Bachelor's of Social Work, having years of service of 15.5 years, and most of them working in child and family welfare services. From the descriptive statistics, it is indicated that with a mean of 9.4 for overall knowledge, it indicates that respondents had a low overall knowledge of older persons. It translates into 37.6% correct answers. Positive bias and negative bias measured low. For attitude, the overall score was low with a mean of 80.6 out of a possible 145, while for the constructs, only discrimination measured high. We went further to determine the impact of 9 factors on the knowledge and attitude of social service professionals towards older persons, namely age group, area of childhood residence, growing up with an older person, highest qualification, completed a course or module in gerontology, working exclusively with older persons, consider working exclusively with older persons, province where the respondent works, and task description. From the independent t-test, it is indicated that for positive bias, it was found that those respondents who grew up with an older person score statistically significantly lower on positive bias. When considering ageism, it was found that respondents who were working with older persons scored statistically significantly higher on ageism, with a similar finding for anti-locution. When considering the results from the one-way ANOVA and specifically interpreting the Bonferroni postdoc test, it was found that for the overall knowledge of aging, that those participants who were in the young adulthood or middle adulthood had a statistically significantly lower knowledge of aging than the colleagues of 60 years and older. Furthermore, it was found that those with a postgraduate qualification scored statistically significantly higher than the other categories, and those who worked in management positions also had a statistically significantly higher score than those working in other categories. What are the conclusions and the recommendations? First of all, South Africa has a policy for CPD for this professional group. The knowledge could be addressed by introducing the respondents to a course focusing on gerontological social services and not only on life course development. Formal learning programs could be developed, short learning programs could be developed and implemented, and workshops could be rendered. In terms of attitudes, group supervision could be held where respondents are exposed to video material and addressing typical stereotypes about older persons or working with case studies, or the allocation of older service users to professionals and offering them guided supervision to ensure appropriate service delivery. I thank you for your time and interest and looking forward to any questions you may have.
Good morning, everyone. My name is Graciana Najim, and I was chairing this oral presentation. So now we're gonna start with the Q&A. So I will see if there's any question for our speakers. Well, I can see I have a question from Chu Elena for Dr. Gloria Goodman. I have a question. Thank you very much for your very interesting presentation. My question is about the marital status. Have you looked at any similarities or differences between individuals for different marital status? For example, married, single, divorced, widowed. Thank you.
Yes, we have quite a bit of information about the characteristics of each of the participants in the study. And so our more sophisticated analysis did look at the demographics and some of the other variables. But in this presentation, what we wanted to do was look specifically at the issue of gender and sexuality, because there is such a small literature which suggests that LGBT people are more susceptible in a disaster situation, but there's very little hard data. So this one, we were pleased to find that in fact, this group seemed to be more resilient and in coping with the disaster of the pandemic.
Thank you, Dr. Goodman. Well, if there isn't...
I do have a question again for Dr. Gloria Goodman. Thank you so much for your answer. It is very good to see that the marital status was actually in the data, it's just not presented. I was really wondering why the heterosexual men would be basically the least able to cope compared to the other groups. What would be your speculation? Why, when the hypothesis, we're expecting the LGBT people to be more vulnerable and the result is actually the opposite. What would be your speculation?
Yeah. Well, from other research that we've done, many of these people, older adults, have lived through the AIDS situation, and so they are survivors. And in that sense, we're more proactive. Like we have found that more of them complied with public health kinds of directives than the other group. What we also see is with men would seem to have more negative consequences. In particular, it's because of many of them, more of them are working. And so they're caught, in terms of consequences and stresses. We have to think about the issue of the loss of jobs, or of having to work from home, or from the various kinds of things that social distancing and putting on masks and so on have done to our social relationships.
Very interesting, Dr. Goodman. I really, really enjoyed your presentation. It's a topic that it's really interesting.
Well, I thought a number of the presentations today that dealt with sarcopenia were very interesting. And that particularly that it tends to be underdiagnosed and that it can be improved with electrical stimulation. So maybe we can hear a little bit more about those things.
I agree. Yeah, that's. If you want to say some words about it, Doctor.
In our study, I'm a geriatrician, so also the clinical director, and we have a good fight with the state of the number of appointments and the time we have to work. So even we having the knowledge about sarcopenia and everything, most of the time that the time we had to have with the patient is very small, and they bring a lot of demands and problems that they don't they aren't resolving in the primary care. So when they come, they bring other questions, other problems, and sarcopenia is almost all the times left behind. So with this study, we saw that our professionals know, but doesn't have time. And our service is new, has only 5 years. So we are constructing the service. So it was good to know that we need to be intelligent to find other forms to investigate sarcopenia. Not only the physicians, but all the professionals. To have the best treatment for them and not centered in the physician, and also to start how can I say, a capacitation with the primary care about sarcopenia, because we need just a little bit of stuff to do it. But we saw that in our study 100% wasn't question about sarcopenia. Wasn't diagnosed of sarcopenia. And what we saw is that almost 50% of the patients consider normal to fall, to tumble, and 50% also of the doctors doesn't question, the patients doesn't refer, only if they have a hip fracture involved. But if it doesn't, they don't say about it. So it's a huge work of to teach the people, to teach the other professionals the importance of the sarcopenia and all the costs involved, financial and physical and social, and for the head, the sentiment and everything, because a lot of people stop working to begin to be caregivers. So it's a huge problem that we are starting to talk in the last 10 years. So it's interesting to work with that.
Thank you, Doctor. I have another question for you, actually, from Russo Alberto, that he says, the use of food as a supplement in sarcopenia has effects?
Sorry, I didn't understand the first part.
He was wondering if the use of food supplements in sarcopenia has effects.
Yes, it has, but the hugest problem that I see is when we tell to the patient to give a supplement or a vitamin or something, they don't do the most important, that is the exercise. So, of course, we need to do this stuff also, but we need to show them that the most important is that they need the right nutrition, that they need to do the right exercise to get stronger and improve the muscle mass and strength. So it has its paper, but I don't think it's the first the first thing we need to propose to them. It's always a compliment.
Perfect. Thank you. Thank you, Dr. Cruz. Well, I don't see any further questions. So, as I said before, if you like to add something to your presentations. So, well, in that case, I will thank you all. I really enjoyed all of the presentations. I thought they were very interesting. Thank you again for participating in this 22 Congress of Gerontology and Geriatrics. It's been a pleasure for us to host you, and I hope to see you soon, and I hope to be aware of your new work because they are very interesting presentations. Thank you very much to all of you.
Thank you.